Hello, I'm Jan Leichman.
And I'm Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Breelyn Wilky. Dr. Wilky is the Director of Sarcoma Medical Oncology, the Director of Translational Sarcoma Research, and the Deputy Associate Director of Clinical Research at the University of Colorado.
In today's presentation, Dr. Wilky provides a comprehensive background of sarcoma diagnostics.
Did you know that Dr. Wilky has designed and led several early phase clinical trials with new targeted agents and immunotherapies against sarcomas?
She is truly an accomplished pioneer in the field of sarcomas.
So let's tune in and learn from this global leader.
So for those of you who don't know, what are sarcomas? Well, sarcomas are actually a group of over 100 different cancers. They're neoplasms that arise from tissues of the mesenchyme, and these include organs like bones, as well as connective tissues like fibroblasts found in tendons, fat, smooth muscle, and so on. And so collectively, this family of neoplasms makes up only 1% of adult cancers and about 15% of pediatric cancers. All of these crazy names are coming from the cell of origin, and they actually can range from what we call well-differentiated sarcomas, which very much resemble the parent cell, all the way to undifferentiated or poorly differentiated sarcomas that have completely lost their way and become quite primitive, looking very much like their original mesenchymal stem cells. These are commonly our undifferentiated sarcomas. They can occur literally anywhere from head to toe, but the most common presentations are a soft tissue mass, so something that's large and growing, like you might see here, or a flank mass. And these are often mistaken for benign entities like lipomas or an injury-related phenomenon like a hematoma. For abdominal tumors, one you can see here, the symptoms are commonly weight gain, bloating, pain, sometimes a blockage of the GI tract, or even bleeding from an involved intestine. So a ton of variability with this very weird and unusual group of cancers. In general, when dealing with newly diagnosed sarcomas, there are several pillars of management that we want to keep in mind. First, get imaging for any mass in the soft tissue that's bigger than a golf ball, or if it's growing or causing pain. The images we use, like ultrasounds and MRIs, often can reveal clues ahead of time that you're dealing with something more aggressive than a typical lipoma or a hematoma. Next, you want to plan a biopsy approach with the surgeon who's ultimately going to remove the mass. And a careless biopsy can actually violate tissue planes and cause big problems, risk for recurrence later on. Once you have your biopsy, the next step is getting it in the hands of an expert bone and soft tissue pathologist. The diagnosis can change up to 30% of the time when it's reviewed by an expert, and it's really critical for our treatment decisions, as we'll talk about a lot today. Next, reviewing at a multidisciplinary center. So go to a sarcoma center to come up with a treatment plan, or send your patients to a multidisciplinary center. They can still receive treatment locally, but getting everyone's input into optimal management is really critical for the best outcomes. Part of that multidisciplinary workup includes staging scans, which will look for metastatic disease. The most common site for this is the lungs in sarcoma. For truly localized disease, complete surgical resection with wide margins is critical. For borderline resectable or disease that's growing quickly, sometimes our team will consider neoadjuvant treatment or treatment before surgery to control or downstage the disease before attempting a resection. And then finally, we consider radiation and chemotherapy for high-grade or aggressive extremity sarcomas. So I like to talk about treatment really in classifying in three major categories for all those different sarcomas we were talking about. And so we'll talk about this for a minute here. So the first class is our chemosensitive sarcomas. So these tend to be our pediatric subtypes and include diseases like osteosarcomas, Ewing sarcomas, rhabdomyosarcomas, and synovial sarcomas. So for many of these, there's up to a 70% cure rate with standard old school chemotherapy, but it's intense, it's long, and there's a lot of drugs involved. Unfortunately, for patients that developed relapsed or refractory disease, there's been very few advances made in management, and this carries quite a tough prognosis. The other thing is that adults can actually get these pediatric sarcomas. And one thing that's important to note is that the outcomes actually aren't as good in adults. And there's several reasons for this potentially. First of all, adults may not be able to tolerate the intensity or the length of chemotherapy like kids can. There's a question about why these develop in adults to begin with, when they're supposed to be more common in children. So probably a different biology playing a role. And then often our adults are not eligible for pediatric trials due to age limits and so on. So they're challenging to deal with in the adult population. The next group of sarcomas that we think about are chemo-resistant. So we never use traditional chemotherapy for many of these types. Fortunately, with some of the advances in modern molecular technology, even the rarest of the rare subtypes of sarcoma, we're finding molecular alterations or genetic changes that are conserved and often druggable with new therapies. These tend to be chemotherapy pills or targeted therapies that block particular molecular signaling pathways. So just to show you a few examples, several sarcomas are closely associated with something called vascular growth factor or blood vessel pathways, so VEGF-related disease. These can respond to VEGF targeting chemotherapy pills like solitary fibrous tumors and alveolar soft part sarcoma. Chondrosarcomas, these are cartilage cancers. They often have IDH1 or 2 mutations, and we can take advantage of drugs that are recently approved for other cancers like leukemia that have IDH mutations. Pecomas, this is an extremely rare type of sarcomas that have alterations in a pathway called mTOR, and we actually just approved a brand new drug specifically for this tiny group of sarcomas called nab-sirolimus. Gastrointestinal stromal tumors, these are actually much more common, and you'll actually see these on a regular basis. So these are driven in the vast majority of the time by activating mutations in KIT and PDGFR. And so there's several chemotherapy pills to target these types of sarcomas, including 2 recently approved drugs, ripretinib, approved for 4th-line treatment of GIST, and then avapritinib, which is approved for one very specific resistant type of PDGFR GIST that's resistant to imatinib. And then finally, these are 2 benign sarcomas. However, they're locally aggressive and cause a tremendous number of problems. So tenosynovial giant cell tumor is a disease of joints, and it's driven by a protein called CSF1. And we just approved a drug blocking CSF1 called pexidartinib. And then giant cell tumor of bone responds very well to denosumab, which blocks RANK ligand. So this sort of gives you a flavor for how we can customize treatment and why it's so important to get the diagnosis right, knowing any particular druggable genetic alterations. And then finally, the third class, the others. So unfortunately, this is what we most commonly see in our clinic. These are our common adult subtypes like pleomorphic sarcomas, liposarcomas, and so on. Unfortunately, here there's limited activity of cytotoxic chemotherapy as well as targeted therapies. So what I'm showing here on the right is a list of chemotherapy drugs that have been approved or that are commonly used in sarcomas. And unfortunately, over the last 40 years to date, no drug or combination of drugs has improved overall survival for metastatic sarcomas like these above doxorubicin alone. But even if you look at doxorubicin and any of these drugs, the overall survival is still only 12 to 18 months or so. So we need to do better, and we need to find other treatments. The progression-free survival, which is how long the disease is stable with any of these drugs, ranges anywhere from 2 to 6 months. So we still have a lot of work to do. Targeted therapies, again, we recently approved tazemetostat for epithelioid sarcomas, which is great. And there's many ongoing trials looking at CDK4 inhibitors for liposarcomas. But again, these are palliative treatments. We're not getting cures here for this group of diseases.